I have no disclosures or conflicts. So bypass, we talked about earlier today, is historic gold standard. This involves usually autologous vein conduit. It can also involve prosthetic and also cadaveric vein. Here's a schematic looking at a autologous bypass on the left and a synthetic bypass or prosthetic bypass on the right. Autologous vein can encompass greater saphenous vein, either ipsilateral or contralateral, arm vein, and also small saphenous vein. And these are more common veins used in the leg for procurement. Arm vein can also be used, often the cephalic basilic vein, sometimes a single segment, sometimes spliced, and sometimes a complete upper extremity loop. What is a threatened bypass? How do we find them? Oftentimes we find these by screening patients post-operatively, usually with a duplex ultrasound, looking at velocities through the bypass graph, but also looking at ABIs and PVRs and toe pressures and correlating the two things together. Things that make you concerned: a severe stenosis based on the velocity, usually a 3.5 increase in speed is considered severe stenosis. Low flow in a bypass, which usually 45 is the number we use as a cutoff for being a low flow bypass, especially if this is conjunction with stenosis either proximally or distally, or also change in just perfusion and pressures. You might see moderate stenosis, but the ABIs or toe pressures may have dropped, or your PVRs may have changed. So you need to look at the whole study in the whole context to get an idea what's going on. And also the old-fashioned way too, just a good pulse exam and a physical exam too, can also help you think that there may be a problem. This is an example of a bypass I had. You see here that distal graft velocities are 28, which is low. 45 centimeters per second is kind of what uses the cutoff. But I also don't see an overall stenosis here. Sometimes these cases are challenging, and oftentimes I'll probably end up doing an angiogram on this patient, and it could be, you may see a stenosis, you may not. You may see a very dilated vein, which can lower your velocities, or you may see significant distal disease that really is not either amenable or non-amenable interventions that may be causing this lower velocity. What can you do for a threatened bypass? Well, you can follow it. You do an angiogram. You can assess your inflow, the outflow, and the bypass itself. Because your bypass may look great, but you may have low flow in your fem pop because you have an iliac veins, iliac artery stenosis, or you may have worsening tibial outflow disease that you're not appreciating. Ways to intervene: there's angioplasty, simple angioplasty of the vein. Some people use cutting balloons or scoring balloons to get a little more involvement of the stenosis to help open the vein more. I get concerned about this sometimes. I worry about rupturing the vein, especially when going to bigger sizes like balloons. And also coronary stents as well. I'll place occasionally in a vein bypass if I have residual stenosis that doesn't get better with a balloon. And also the old-fashioned way, doing an operation, cutting down and patching the vein with either another piece of vein or a bovine pericardium or other kind of patch. So that's always also an option as well when endovascular means fail. So what's the data out there? Looking at a Cochrane review, this is what the Cochrane review found. There really is no data on it to guide the type of intervention, open or endovascular, for a stenosis in a vein bypass graft infrainguinal bypass. So what is out there? Some single centers out there of who may end up with a problem. Retrospective analysis of 353 infrainguinal bypasses. A little over a third had secondary interventions, most of which were operations at this point. There's a little bit of an older paper, and actually, sorry, less than that. And this is often based on duplex studies. Things that end up people getting stenosis initially were initial moderate stenosis after an intervention, often progressed to having a significant stenosis that it intervened on, a non-single segment saphenous vein, and also redo operations as well. Is it related to technique or not? Looking at 338 single center infrainguinal bypasses, there's about a third in site 2, third reversed, non-reverse translocated or spliced upper extremity veins. So revision or failure of reverse vein bypass was 2.5 times than in situ or a non-reverse vein, which actually I'm a reverser, so that actually makes me unhappy to see that. And bypasses modified the operation during the time initial operation that had were 2 times as likely to need a revision eventually as well. So if you don't like it in the first place, you may end up coming back again in the future. And that's pretty much common in a lot of things in vascular surgery. Here's a case I had. This is a posterior tibial artery bypass I did. And on follow-up, I was very happy with the bypass. It was for rest pain. She was doing pretty well, still had some symptoms. And on follow-up, she had a severe stenosis distally, and she still had pretty low disc perfusion in her foot on her toe pressures. So I took her for an angiogram. You clearly see here, you see my beautiful vein coming in, going to the posterior tibial artery, but then it goes nowhere. And really the only reason why this bypass is still open is because it's a retrograde filling and some collaterals filling the artery distally. Clearly, this is my Yazago clamp that injured the vessel there. One option would have been complete angiogram, which I don't routinely do, but I'm more open to doing it now after this case. And also, one of my partners, Dr. Farber, who spoke earlier, always uses a tourniquet to avoid this exact situation. So you come here, and you can see here, I got my balloon through there, did balloon angioplasty afterwards, and we had a great result afterwards. And her bypass has been open for 4 years now. This is another case here. This is a bypass which didn't have great flow at the end of the case, and you see it's open again by retrograde filling. You got distal. The artery was thickened on the inside more than appreciated initially, and most likely an issue from the clamp. So either you can take this down further and it's not filling well distally. Either you take this down further and go down further in the bypass, or you can do something endovascular. So we got a wire down, performed an angioplasty, had a beautiful result afterwards. I guess this would fall in the category of needing to be done during the initial operation. It puts it at high risk of having done in the future. But if it doesn't seem right, do an angiogram if you don't routinely do it. And you may have an endovascular option to fix this, because you very easily see this would not have fixed this patient's rest pain problems, and this bypass easily could have gone down. What about occluded bypasses? What are your options for these? One is lytic catheters. You can place a lytic catheter in. You can drip TPA overnight, and you can come back and see how it does. That's the most conservative way of doing it. I had a patient in my first year in practice that one of my senior partners said, "Hey, that guy's bypass is down. Can you just put a lytic catheter in, and I'll take it back the next day?" Sure, no problem. He's a 78-year-old man, with the usual comorbidities, and he became obtunded on the way down the elevator, going back for his take back the next day with my partner, and had a big head bleed. So splicing TPA overnight is not necessarily risk-free. So you have to keep in mind there are other options as well. Some people do ECOS for shorter time and better results, ultrasound guided, ultrasound catheter. I've done angiojet procedures before, where you go in with the angiojet and you open it up. This can help debulk clot, and allowing, if you want to leave a lytic catheter, to have less clot burden during the time for it to work. And you may have decrease your lytic time as well with that. There's a 6 French one they can use. There's a smaller one you can use to get down the foot if you need to. And also there's a bigger 8 French one, the Zalante, that you can use that has directionality to it. There's also the newer, though I guess not so new anymore, penumbra catheter, which can be used at one stage without lytic therapy to get grafts open, which I've had some success with as well. So this is a case here. There used to be a bypass here coming off. You can almost see the hood of the bypass higher up here, and this is completely occluded over here. And it would get a wire through, do angiojet, and actually did end up dripping some TPA in the patient as well. Perform balloon angioplasty. And there's still a residual stenosis at the very proximal bypass you can see coming off, which made me worried that was the failure point. The rest of it looked good, and that was going to be a problem. So I placed a drug-eluting coronary stent there, and this bypass has done well and been open since then for about 2.5 years. One other option would have been an open surgical repair at that point or a scoring balloon. But I worry with the vein being relatively small, that is a good chance of rupturing this bypass. And at that point, you're going to have much more limited options. So what's the data for treating failing bypass grafts? With single center retrospective review of patients with revision of failing grafts had 45 angioplasties in 36 patients. Initial success was achieved in most patients, and assisted vein bypass patency rates are 87, 83, and 79% at 6 months, 12 months, and 24 months, respectively. And overall, the patients did well, though 2 patients developed thigh hematomas. 1 required an operation, and 1 did okay and was able to be observed. So overall, surveilling your veins or bypasses over time and intervening on them with minimally invasive methods can preserve these bypasses for a longer period of time. We see this both in bypass with lower extremity bypass and also with AV access as well. A lot of similar techniques and overlap in what we do and how we do things. Though we generally don't screen them with duplexes here in the US for the access cases, but the bypasses we do. I'll see a bypass for the first year every 3 months, and then afterwards usually every 6 months with a duplex and AVIs, PVRs, and toe pressures. So if we're looking at surgical and endovascular interventions, this is a little bit of an older paper, but evaluating stenosis-free patency of open repair during there's 77 open procedures and 67 angioplasties, and there was really no difference in 2 years at need for intervention or restenosis between the surgical group and the endovascular group. And also looking at outcomes of endovascular interventions for infrainguinal vein graft stenosis. They use a peak systolic velocity of maybe 300 here. Their timing range from 1 month to 252 months, so a little over 8 years there, and with a mean of almost 2 years. Stenosis-free patency after angioplasty was a little lower than the other group we saw, 58-55% at 6 months, 54% at 1 year, and 45% at 3 years. And stenosis-free patency at 6 months was lower in patients with a recurrent stenosis than primary stenosis, which does make sense that if you repeat, interventions tend to yield over time repeated interventions on a lot of people. What about cutting balloons? We mentioned cutting balloons earlier. I tend to be a little conservative using cutting balloons because I don't want to rupture my bypass. I would put a stent in generally before doing a cutting balloon. Comparing cutting balloons, standard percutaneous balloon angioplasty, or open revisions. So looking at 161 lesions and 124 bypasses, they had a pretty evenly distributed open surgical angioplasty and cutting balloons. Stenosis-free patency at 48 months for the open surgical, the cutting balloon, and the angioplasty were 74, 62, and 34% respectively. So you can see the cutting balloon outcomes were closer to the open surgical outcomes, with the angioplasty faring worse off. Angioplasty and multivariable analysis was associated with increased failure compared to open surgical interventions, and also with the cutting balloon. There's no difference between cutting balloons and open surgical intervention. They did have 2 pseudoaneurysms in cutting balloon patients, one which ruptured and required an interposition graft, the other one did okay and was observed. So in conclusion, endovascular methods can salvage vein bypasses. There is low morbidity. Open surgical options still remain an option, and some places are considered the first line still. There's need for continued monitoring and maybe future interventions. Cutting balloons and coronary stents may be useful as adjuncts to interventions to help improve patency. Thank you.